in the field talking to us. So let me call upon Dr. Chitra Ramamurthy, who will be giving the keynote address on ASOCT guided management of posterior polar cataracts. Dr. Chitra doesn't need any introduction. She's the medical director of the Eye Foundation Group of Hospitals and a prolific phaco-refractive surgeon and a great leader of AIOS and TNOA. Over to you, Dr. Chitra Ramamurthy.
Very good morning to one and all of you, and thanks so much, Dr. Soni, for a very kind introduction. So without wasting time, I'm going to take you on to how anterior segment OCT based management of a posterior polar cataract gives us a greater ease in identifying which are actually routine cases. Now, all of us are familiar that in a polar cataract, we make a smaller excess because there's a possibility we have to place the lens on the excess. We will not do hydrodissection. We will do a mechanical delamination, hydrodelineation. We will not rotate the nucleus. See how eating up the epinucleus and the cortex, getting the endonucleus out, at all time keeping my IOP at 30 millimeter, no anterior chamber fluctuation, and then eat up the entire thing, no posterior capsular polishing. And you never know, at any point of time you may be having a PCR. So it becomes a challenging case. The fact that you have not rotated the nucleus, not done a hydrodissection, it can become time consuming. Now ASOCT shows all these cases as posterior polar cataract. Which are the innocuous one? Which are the ones which are having a posterior capsule open? Is something repeatedly we have come to understand in the recent years that ASOCT, the swept source one, definitely helps you understand whether there's a continuity in the posterior capsule. You could use the intra-op OCT, the OCT guided phacoemulsification, which will take you through the different steps, all the time visualizing whether the posterior capsule is intact. Even femtosecond laser assisted cataract surgery is done. It has the swept source anterior segment OCT, which tells you whether there's a posterior capsule dehiscent. If not, you don't have to keep a higher offset. So there are any number of papers which have come forward. To understand now the group 1, you are able to continuously see that inferior continuous line which shows that the PC is intact. In the group 2, there is that hazy smudge, and you're not able to trace the posterior capsule under that opacity. So it's discontinuous, which means the PC is open or likely to be open. And in group 3, that PC is actually dehiscent with the contents are already in the patellar fossa. So in group 1, where it is a PPC with a continuous posterior capsule, now I'm going to tell you what differently you can do. What you can do is you make your nice round rexus. You are cognizant that this is a weak posterior capsule, but you can do a hydrodissection. You have seen PC continuity. There is no harm in doing a hydrodissection. Keep your IOP low, keep your parameters low, but you can rotate the nucleus. Everything in a gentle manner. Do your chops, remove your cortex, and you could even dare to polish the capsule if you want. See the posterior capsule intact, carefully inject the IOL, but then it's a safe procedure. If you were to do on a femtosecond laser platform, there are certain things, the manipulation in the anterior chamber is so reduced, the capsular excess is free floating, and all those fragments are already created. You can gently rotate, and you can just carousel it out, eat it up, keep your IOP low. I agree that it's a posterior capsule to be watched, but in that group 1, wherein you are seeing an intact posterior capsule on ASOCT, are definite cases where you can do a routine cataract surgery and not make the surgery a challenge. And sometimes the complication is not because of the posterior polar cataract. Here I have even dared to do a posterior capsular polishing, which normally we may not. We need not dare to do that if necessary, but you can get away. Now these are the group 2, where the posterior capsule you can't trace. Look at the ASOCT. You're not able to trace it. So then How would I do my surgery? Now, herein again, I would make a small recess. Because here, I will not do a hydrodissection. I would only do a hydrodelineation. I see that golden ring. And I'm not going to rotate the nucleus. I'm going to debulk the superficial epinucleus. Then I make a small trench because it's a moderately hard cataract. And then this gives me a better approach to do my direct chop. Now let's remember, I'm not rotating, but with at visible area at the 6 o'clock, I make 2-3 pieces, loosen them up. And once I eat one piece, I have created more space in the posterior capsule. The intracapsular pressure is reduced. So I can even do a viscodissection now. And then I would rotate the nucleus and chop it into further smaller pieces. But all the time when I remove my instrument, I would inject viscoelastic. I would not want to have any change in the hydrostatic pressure in the posterior capsule. I will keep my phacoprobe in the center and complete the case. Now here, the PC is dehiscent and the contents are in the patellar fossa. So that means the PC is open. So you are sure shot operating on an eye where the posterior capsule is already open. You know there could be a nucleus drop. So this is a very careful surgery. Hydrodissection, no rotation, hydrodelineation, no rotation. I've completed the surgery. But see, the vitreous is not there. Although there seem to be some the disturbance in the anterior vitreous. And I've managed to place the premium IOL in the capsular bag and got away. We did an analysis of 71 eyes of 49 patients operated by 5 surgeons in the period of 7 months. There were 54 eyes in group 1, 16 eyes in the group 2, and 1 in the group 3. Now, in the group 1, there should not be any PCR, but in this one particular surgeon was a little careless about the steps of the surgery, which only induced that PCR and not because it was a polar cataract. In the second case, out of 16, there were 4 eyes. So although the OCT said, ASOCT said that there's going to be a rent, but it was so only in 4 eyes. So 25% only predictive value was there. And as far as the IOL placement, out of the 54 eyes in group 1, in only 1 it was placed in the sulcus with optic capture. In group 2, there were 13 of them could be placed in the bag, and only in 3 of them an optic capture and reverse optic capture was done. And the most interesting thing is, we had promised premium IOLs in whichever patients, all of those patients, in spite of the being a polar cataract, we did not have to change the IOL and we could place the IOL. So what did we understand? ASOCT is helpful in predicting with an intact PC. In 98% of the case, it is sensitive, which is very important. So you will not go wrong if you do a hydrodissection there. Specificity. Out of 16 cases, 4 cases only had PCR, whereas all should have had PCR. So the specificity is only 25%. In other words, the high negative predictive value is 98%, and if it is intact PC, it is not likely to have a PCR. Then, what is the reason for those eyes where the opacity was there and discontinuity was seen? And in group 2, probably the PC plaque is so thin that the ASOCT beam could not pass through. Probably there are only tiny defects which were there, but it was still a continuous PC. Probably it was a very thin PC, but actually it was intact. That's why you didn't have a PCR. So I would like to conclude stating that ASOCT should be routinely performed in all cases of PPC. If PC is found intact, do a routine phaco. Care should be exercised. However, the PC, though intact, can be thin, and all deficient PC do not end up with a PCR. So thank you very much. And since I'll be leaving today by afternoon, in case I have not met some of you in this audience, I'm contesting for the post of Vice President of AIOS. I have been a chairperson ARC only because of you all who voted for me in the earlier election. So please do remember me. I'll give my best to you all. Thank you very much.
Thank you, Dr. Chitra, for that, as usual, wonderful presentation. I only hope more of us can afford OCTs while doing...
no, even the IOL Master OCT will give us an idea. And I think maybe it's the next thing. It will help us a lot. It's not that if you presume even the grade 1, we treat it as a PPC and don't do a hydrodissection, it's okay. It's all right. It's just that the surgery can go faster because you're overcautious in a case where we need not be.
Thank you. And all the best for your elections, ma'am.